Okay. Greetings, everybody. I hope everyone can hear me. Um, Thank you all for taking the time to join this briefing hosted by the Women's First Research Coalition on how to address inequities or disparities in women's health through research. I'm Melissa Simon. I am the Vice Chair of Research in the Department of Obstetrics and Gynecology at Northwestern University Feinberg School of Medicine. I also am the founding director of the Center for Health Equity Transformation, and I lead a broad-based research unit and mentorship and education unit focused on all things health equity, especially at that intersectionality of racial and social justice and women's health. I am very pleased to be a co-chair of this coalition with Dr. Nanette Santoro. And so before we begin, I want to go over a few housekeeping items. We are using Zoom's webinar format, and all audience members are muted throughout the discussion, but we will be taking questions at the end. And to ask a question, please use the question and answer function to type your question, and you can start submitting questions now and throughout the briefing. When submitting a question, be sure to include your name and the full name of your organization or your office with your question. We also recommend switching the view to hide all non-video participants. I would also like to note that this briefing is not open to the members of the press. So if you've joined us inadvertently, we appreciate your interest, but would kindly ask that you would disconnect at this time, and we'll be happy to follow up with you separately. As you know, the National Institute of Health's mission is to seek fundamental knowledge about the nature and behavior of living systems and the application of that knowledge to enhance health, lengthen life, and reduce illness and disability. The 27 NIH institutes and centers fund a wide range of biomedical, behavioral, and population-based intramural and extramural research. And I'm very fortunate that I've been funded across 7 of these institutes. The Women's First Research Coalition formed because women represent half the US population, and the conditions and diseases that are specific to our health, or those that present differently in women than men, must be a priority for federally funded research. And although significant changes in research design and practice have increased the proportion of women included in research trials in the recent past, knowledge gaps remain because of the continued lack of adequate inclusion of women, including women of color, and especially those who are pregnant or breastfeeding. Besides including women in research, including those from diverse and underrepresented populations, research needs to be conducted on conditions that are unique to women or affect women differently than men, and that intersectionality. And we are seeing this especially with COVID, and I'm going to talk about in the next minute. We understand that Congress provides funding for all of NIH rather than institute by institute or condition by condition, but the WFRC has noted the disparity when it comes to funding women's health and conditions unique to them, and this must be addressed across NIH broadly. We've reviewed publicly available data, and right now the total NIH funding increased by 25% from fiscal year 2008 to 2018, but the total NIH investment in research related to women's health, according to women's health research categories, only increased by 2% over the same period. And at the same time, the United States is facing a maternal mortality crisis, and our understanding of cancers unique to women is not growing at the same pace as other cancers. And in cardiovascular disease, there's significant opportunity to expand research. So those are just a few things, and our esteemed panelists that I'm going to introduce after my slides will highlight that even better. So first, I'm going to give just a little bit of background and frame health equity first. I'm going to just share my screen. And this. Okay, I think you can all see my screen. So I have to say I'm a United States Preventive Services Health Force Task Force member, and so my views don't necessarily reflect theirs. So why are we using the word equity, and what's the goal? The goal is to get to justice. So if we talk about what inequality means if I had a tree and you were standing under this tree, and the tree was bent, the angle, the side to which the tree bends, the apples are going to naturally fall easier in that person's hands as opposed to the other person on the other side of that tree. But then if you move your eyes to the upper right-hand corner of that screen, equality, if we say, well, we should have everything equal for everybody, well, then that means we give everybody the same lift or the same height ladder or the same kinds of supports, and expect everybody to thrive. But unfortunately, if the tree is fundamentally bent to one side as opposed to the other, then we've got a problem, because only one side that gets those supports or that particular type of lift will benefit from the apple tree again. So it perpetuates inequity. So now in the lower left-hand corner with equity framework, we recognize then if we want everybody to get an apple, if that's our fundamental goal, then we've got to acknowledge that the tree is bent in one direction. And then we have to say, okay, since the tree is bent in one direction as opposed to the other, then we must give a different lift for the people who have a harder time or need an extra boost to get to that apple. So the person on the right side of that tree is going to have a higher lift requirement than the person on the left side of the tree where the bent is favoring. But finally, the justice framework, and that's where the inequity research really needs to go, is asking the crucial question of why is the darn tree bent in the first place? And how do we unbend the tree? And I say unbend and not straighten because initially we may not have to, we may not straighten the tree to actually improve the outcome. We may actually have to bend the tree in the other direction or do something else with the tree. But that is the fundamental question we've got to aim towards, is asking the question, why is the tree bent and how do we unbend it? And that applies to everything we do, whether it's research, clinical care, policymaking, etc. So we have to unbend the tree. And one big point that drives a lot of inequities in health, and especially at that intersectionality of women's health, and is racism. It's fundamental cause of disease. Race is not the risk factor, it is racism. Dr. Kamara Jones, her definition is wonderful. Racism is a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is what we call race, and that unfairly disadvantages some individuals and communities and unfairly advantages other individuals and communities, and saps the strength of the whole society through the waste of human resources. So again, the tree's bent in one direction and not the other. So the National Academy of Medicine in 2017's Communities in Action report, which is a really good framework to use if you're looking for a good resource, really shows that social determinants of health that you hear a lot of scientists these days and public health officials talking about, all that, like public safety, social environment, transportation, education, employment, housing, etc. Those are all things that impact health, but racism, especially systemic racism, so institutional included in that, and structural, impact how these policies are formed. And health in all policies is a true thing. And so we see that playing out in COVID. The other really good reference of how racism can get into your biology and your being is from Dr. Williams and team from Harvard in Health Services Research in 2019. This is kind of the house that racism built. And if you look at the basement part where individual discrimination experiences and the weathering hypothesis and can really impact psychological response, biological response, behavioral response, healthcare use response, and health outcomes. And that all leads up to the house, where if you add institutional and systemic racism and structural racism on top of everything, that further impacts all of this stuff. So housing segregation, right, redlining, education, and all these differential distribution of resources in communities impacts health significantly. And we obviously have a long history of discrimination and slavery and racism in this country. But especially in women's health, we have to acknowledge in women's health, the godfather of GYN, Dr. Marion Sims, did multiple surgeries without anesthesia on 12 enslaved women, most notably Lucy Anarcha and Betsy, to really found some of the critical procedures that we do in gynecology to this day. And we've also have unfortunately experimented on women, especially in Puerto Rico, around the birth control pill development. And forced sterilization has been rampant in our country for Black, Indigenous, and Latinx women, and even to this day with forced hysterectomy. So that's how we've gotten here. And we know that there's a lot of disparities that are going to be talked about in the next 3 presentations. And we have this intersection of 2 pandemics, the COVID-19 and racism. And we really do see the 2 different cliffs where some people are more vulnerable and on the edge of the cliff, the green people in this figure, with no supports, and some people are more advantaged. The tree is bent towards them on the other part of the cliff where there's a fence to prevent them from coming off the cliff, or and a safety net if they fall through the fence, and an ambulance that functions to a hospital where they have insurance, and that supports them. So that intersectionality really has created a bad situation and made it worse with COVID-19, especially for Black, Indigenous, and Latinx populations. And we see that even in the data across data sets for pregnant persons, for even 44.7% of pregnant persons are Latinx who've suffered from COVID, and 21% Black. And so in my final slide, I just want to mention that there are some great policies that we really appreciate thus far that are going through Congress. The Momnibus is comprised of 9 individual bills with the Black Maternal Health Caucus. And this is one example of where researchers, including myself, have weighed in to with a variety of representatives who are leading or who are spearheading this effort to really try to shape policies that could improve maternal health inequities. And so with that, I'm going to introduce our panelists. And I'm going to stop sharing. And I'd like to introduce the 3 panelists that we have. Dr. Diana Bianchi is the director of the Eunice Kennedy Shriver National Institute of Child Health and Human Development. She oversees the Institute's research on pediatric health and development and maternal health, reproductive health, intellectual and developmental disabilities, and rehabilitation medicine, among many other areas. She's spearheaded efforts on the NICHD strategic plan, which was released in September 2019, which outlines goals and aspirations to guide the Institute research for the next 5 years. She also oversaw the crafting and vetting of the Institute's new vision statement for healthy pregnancies, healthy children, healthy and optimal lives, as well as its new mission statement. Dr. Bianchi's translational research focuses on 2 broad themes: prenatal genomics, with the goal of advancing non-invasive prenatal DNA screening and diagnosis, and investigating the fetal transcriptome to develop new therapies for genetic disorders that can be given prenatally. Dr. Judette Lewis will talk next, and after Dr. Bianchi, and she is the department chair for the Department of OBGYN at University of South Florida. She's a specialist in maternal fetal medicine and serves as the president of the Society for Maternal Fetal Medicine. She also has a joint faculty appointment in both the College of Public Health and the College of Medicine. Her research in obstructive sleep apnea and pregnancy in pregnant women has led to a career focus on maternal morbidity and mortality. She's authored numerous scientific articles and book chapters on sleep apnea and maternal morbidity and mortality. Through her work as a clinical leader for the Florida Perinatal Quality Collaborative, she has led statewide programs to improve management of obstetric emergencies in Florida. She's passionate about making pregnancies safer for all women, and in particular, improving maternal health across the lifespan. And finally, but definitely not least, Dr. Marcela del Carmen is the Chief Medical Officer of the Massachusetts General Physicians Organization and Professor of OBGYN at Harvard Medical School. Her research interests include the surgical treatment of gynecologic malignancies, specifically ovarian cancer, the management of rare gynecologic tumors, and improving access to healthcare services for underserved populations. She's been a principal investigator of clinical trials evaluating novel therapies in the treatment of ovarian cancer, as well as design of a novel device for the delivery of intraperitoneal catheter. Dr. Del Carmen has authored over 200 papers in peer-reviewed literature and a textbook. With that, I will turn it over to Dr. Bianchi. Thank you, Dr. Bianchi.
Thank you so much, Dr. Simon. May I have my slides, please, Erica? Thank you. Next slide. Nope. Good afternoon to those of you who are in the Eastern time zone. It's really quite an honor to be addressing all of you. I am, as Dr. Simon said, the director of the Eunice Kennedy Shriver National Institute of Child Health and Human Development. And as I frequently say, our name doesn't really describe everything that we do. May I have the next slide, please? So in my 10 minutes today, I'm going to briefly go over our NICHD strategic plan, NIH-wide initiative on maternal morbidity and mortality, how the NICHD is starting to address COVID-19 in pregnancy, and then another important initiative on the task force on research specific to pregnant women and lactating women, which we fondly call PregLac. Next slide, please. After an almost 2-year process, we released the NICHD strategic plan just about a year ago at the very end of 2019. And I think it's important for everyone to recognize that, first of all, we don't exclusively deal with pediatric research, and virtually everything that we do, including the first theme, understanding the molecular, cellular, and structural basis of development, really relates to women's health because that theme relates to development of the reproductive organs. We have a major portfolio in gynecologic and reproductive health, meaning that we are funding research on disorders that are specific to women, such as endometriosis, fibroids, pelvic floor disorders, etc. Of course, a big part of our portfolio is pregnancy, and it's important. I think obviously the OBGYNs in the audience know this, but it's important to know that pregnancy is a stress test for later life. And if a woman develops hypertension during pregnancy, she's very likely to have hypertension after pregnancy and is at higher risk for cardiovascular disorders. The same is true for diabetes. And a big part of our portfolio now is this interest in advancing safe and effective therapeutics and devices for pregnant and lactating women. This is a hugely underserved area. And remember, we finalized our strategic plan a year ago, but we made a major commitment to both health disparities and infectious disease. And this was all obviously pre-COVID. Next slide, please. Next slide. So I don't think I need to remind many of you what a big problem maternal mortality is in this country. We are unacceptably high in terms of maternal mortality when compared to other developed countries. There are about 6.3 million pregnancies per year in the United States. And, you know, largely, most of these women are healthy and they get through pregnancy just fine. They give birth to healthy babies. But pregnancy unmasks disparities, whether it's in health or whether it's the result of lifelong health inequities. And so what we really want to do is identify who are the 400,000 women per year who have co-occurring conditions that put them at risk for both what we call near misses, which is severe maternal morbidity, or the 700 to 900 maternal deaths per year, of which 60% are preventable. We recently had a workshop in May, and Dr. Simon presented at that workshop, and we had 2 days of very engaging discussions on how to deal with this issue. Next slide, please. We're including maternal mortality here because there are these significant health disparities. There are definitely racial differences in the risk of dying during pregnancy, after pregnancy, or up to a year after pregnancy. So if you're a Black woman, you have a markedly increased risk of dying. And similarly, if you are an older woman, so the risk begins to go up after age 35, but it's dramatically higher after age 40. These are two major risk factors that increase your chance of dying in the perinatal period. Next slide, please. Now in December, Dr. Collins, myself, Dr. Eliseo Perez Stabile, the director of the National Institute of Minority Health and Health Disparities, and Dr. Gary Gibbons, the director of the National Heart, Lung, and Blood Institute, were invited to present to the Congressional Maternal Black Health Caucus. And at that time, it was a very well-attended early morning meeting in which we were asked, what are we doing to address this problem in the United States in terms of maternal mortality? And this led to the formation of a task force that I co-chair with Dr. Tara Schwetz from the Office of the Director at the NIH and Dr. Janine Clayton, who is the director of the Office of Research on Women's Health. And we have been leading a task force that has wide trans NIH representation. And this has led to an initiative that was able to fund its first administrative supplements just in the last month. The name of the initiative is the IMPROVE Initiative, which is an acronym for implementing a maternal health and pregnancy outcomes vision for everyone. And just seeing the National Academy graphic that Dr. Simon just showed, I realized it's quite similar to what our goals are, because what's a little bit different about the IMPROVE Initiative is it has this very strong community partnership. And we need to communicate with the community to understand in a specific area what is needed. Where are the barriers to getting care, and where can we intervene to get better outcomes? The other part of the IMPROVE Initiative is a focus on foundational biology, as well as social and biobehavioral research. But the biology, at least in the first year, we decided to focus on the areas that the CDC has shown are most linked to maternal deaths. So these include cardiovascular diseases, hemorrhage, thrombosis, mental health issues, substance abuse, and infection. We did include infection, even though it was pre-COVID. We were thinking mainly of flu at the time. So we are incorporating all of these goals while being very focused on health disparities, race, age, and geography. Next slide, please. So on September 29th, we awarded $7.2 million in grants. The majority of these supplements did go to focused research on heart disease and hemorrhage, although a number of them also went to establish community interactions, as well as begin to partner with especially rural areas, because geography plays a role in all of this as well. Maternity deserts do lead to an increased risk of maternal mortality. The fastest way for us to get money into the hands of researchers is to do an administrative supplement. But we recognize that somewhat biases who gets the money, because to get the money, you have to already have an existing funded project. So in the coming year, we are hoping to be able to fund some new projects. And again, our focus areas are heart disease, hemorrhage, bleeding, and infection. But we're very interested in these contributing conditions that predispose women, that put them in that 400,000 group of women who are in less than optimal health, and who not only have these underlying conditions, but are very susceptible to structural factors that will contribute to their risk of severe complications of pregnancy or death. Next slide, please. So I mentioned geography briefly. We have recently had one of our researchers, Maeve Wallace, published in the Women's Health Issues in October, just a couple of weeks ago. What she did is she was examining maternal mortality in Louisiana and looked at the effect of geography. She did her analysis on maternal death in both pregnancy-related and pregnancy-associated mortality. So pregnancy-related mortality is women who die during pregnancy, who die while they happen to be pregnant, but from an unrelated cause, whereas pregnancy-associated mortality relates to conditions that are exacerbated during pregnancy, and the fact that they are pregnant and they have a complication of pregnancy leads to their death. And excuse me, she showed that there was an increased risk of death during pregnancy and up to 1 year postpartum. It was significantly elevated in women who are residing in maternity care deserts. Excuse me. And there were some gap areas, particularly in northern Louisiana, where women did not have access to appropriate maternity care. Interestingly, over 80% of the women in the study did have health insurance. So it was not really an issue of having health insurance, it was having a lack of access to people who could provide appropriate care. So that's another factor we need to include. And fortunately, as you know, related to this study, the state of Louisiana is developing a regionalized perinatal system so that women can be transferred appropriately. And I'm hoping that one of the positive aspects of the COVID-19 pandemic is an increased use in telehealth, so that people will be much more used to reaching out to specialists, say in the closest regional perinatal center with appropriate expertise. But geography matters as well. Next slide, please. And just to let you know what we're doing with NICHD, unfortunately, we did not get a specific appropriation for research related to COVID-19 and pregnancy, but we have been able to make use of existing networks and pivot them to a study of how COVID-19 affects pregnant women. And that study is called GRAVID, Gestational Research Assessments for COVID-19. We're taking the 12 existing units in our MFMU network, which comprises 39 hospitals, and we're basically comparing the outcomes of women in what we call the pre-COVID era from March to December of 2019, comparing them to March to December of 2020, or the COVID era. And we're looking at the medical records to see, the hypothesis is that you would see an increased incidence of maternal health complications, rates of cesarean sections, perhaps preterm delivery, and maternal mortality in this current year as a result of either COVID-19 infection or how healthcare has changed, how prenatal care has changed during the COVID era. And nested within that group, because not all 24,500 women will have tests for SARS-CoV-2, there's a natural history study of 3,000 women who are test positive. And then there's a secondary objective evaluating whether African American and Hispanic women are experiencing higher maternal morbidity and mortality during the COVID-19 pandemic. We're certainly seeing racial disparities in who is getting sick. And in addition, we're trying to make our databases as large as possible. So we've developed common data elements to be able to use additional information. Next slide, please. Just last, because I only have 10 minutes to speak, I just wanted to give you an update on PregLac. Next slide, please. So the 21st Century Cures Act in 2016 recommended a task force be formed on how to do research on pregnant women and lactating women. We met for a little over a year and produced a report that went to the Secretary of Health and Human Services in 2018. And it's publicly available. I won't take a huge amount of time to go through this, but the main thing that we found was there was so little evidence on medications taken by pregnant women or lactating women. I mean, lactating women, there was virtually no evidence. And we recognize that this is a huge gap for both pregnant women and lactating women, where the default mechanism is, you know, the safest thing is to do nothing, to take nothing. And that is not necessarily true. So we really want to change the culture to protect pregnant women through research instead of from research. And we had a series of 15 recommendations. Next slide. And it's great to make a report, but then, you know, if nobody reads it, nobody does anything about it, then it's a little bit frustrating. So we actually worked, the task force had so much fun working together that we, no, in all seriousness, we realized that this was a serious problem that needed to be addressed, and we needed to create an implementation plan. So for the next year and a half, we worked together to design an implementation plan, which is not exclusively the purview of NIH or NICHD, but we had representatives from NIH, the FDA, other operational divisions at Health and Human Services, private nonprofits, several members of major pharmaceutical companies. And we really worked together to figure out how could you implement these recommendations. So we submitted the recommendations to the secretary just about a month ago, and he has agreed with them. And so they are publicly available. And we really go through how specifically to establish priorities for doing research during pregnancy and lactation. And this has really come to a head with COVID because we want to be able to offer vaccines safely to pregnant women when a vaccine is available for COVID. And certainly if pregnant women, and we know pregnant women do get sicker than non-pregnant women with COVID, they're more likely to be in the ICU, they're more likely to have severe respiratory illness. So we want to help to determine that many of the medications that are used in non-pregnant people will be safe for pregnant people as well. So I encourage you to read that implementation plan. And I think that's the end of my slides. Next slide, please. Yeah, so thank you, and I'll be happy to answer questions when everyone is done.
Thank you so much, Dr. Bianchi. It is time for Dr. Judette Lewis. You're up. Thank you.
Thank you. Hi, my name is Judette Lewis, and as stated, I am the president for Society for Maternal Fetal Medicine. I'd first like to thank Women First Research Coalition for organizing this event, and thank you for giving me the opportunity to be part of this esteemed panel. Next slide. Society for Maternal Fetal Medicine, also called SMFM, is a nonprofit association that represents more than 5,000 individual members. The core of our membership is comprised of maternal fetal medicine subspecialists, and we specialize in high-risk pregnancy. Next slide. Yes. High-risk pregnancies are basically pregnancies in which there is the risk of there being an adverse outcome for either the mom or the baby. We know that for us to take the optimal care of the patients and to have the best outcomes, we are dependent on research. Research drives meaningful change in our practice. It gives us the evidence base for what we do, and it helps to improve both mom and baby's health. Historically, though, as has been stated, pregnant women have been underrepresented. They, in fact, have been excluded on purpose from clinical research with the thought that we were protecting these pregnant women or protecting their infants. There was the thought that there was an ethical consideration that by including them in research, you risked there being fetal harm. They've been categorized as a vulnerable population, and therefore people did everything possible to exclude them from research. Just like many other things, there's an unintended consequence to that. And that consequence is that we lack robust data to really drive what we do, whether it's related to medications or the way that we manage these patients. Next slide. Given the real and imagined barriers, the funding that has been available to pregnancy-related research largely comes from NIH. If you could just hit enter again, and again, and again. So what you see here on the slide are the various various categories of research and how much money is dedicated to them. The funding for these projects largely come from NIH. In other specialties such as cancer, heart research, and other areas like rheumatology and psychiatry, you will get a lot of funding from industry. They are invested in testing new therapeutics, and so they will fund those studies. However, everyone is afraid of pregnancy. And so what ends up happening is that when it comes to pregnancy and maternal health, you don't have that same kind of investment. So we are dependent on NIH for the funding for us to develop the scientific basis for what we do for pregnant women and breastfeeding women and all of their health needs in the immediate postpartum period. Next slide. So I'd like to talk about what do we know when it comes to cardiovascular disease and pregnancy and the postpartum period. Next slide. Just as has been mentioned, we know that the pregnancy-related deaths are far too common and the burden is not equal. If you are American Indian or Alaska Native women or non-Hispanic Black women, you are disproportionately more likely to have a pregnancy-related death. Next slide. We know that the unequal burden has been persistent over time. This slide just shows the years 2000 to 2015, 2016. But the reality is if you trace the data back in time, we have seen this data throughout the 19th and 20th centuries. And so it's been a persistent disparity. Next slide. It's also well documented that death can happen up to a year after delivery. And so the risk doesn't go away just by delivering the infant. In fact, if you look at the proportion of pregnancy-related deaths, 33% will happen 1 week to a year after delivery. So that indicates that that is a period of time that is still very important for women who've gone through a pregnancy. Next slide. In this figure, there is a breakdown of what the causes of pregnancy-related death are. And I would like to highlight that the largest category is the navy blue category that indicates that cardiovascular conditions are the most common cause of pregnancy-related death. So if you put it all together, we have something that is a tragic outcome, that the occurrence goes on for a longer period of time than people previously appreciated. And we do have a category that can be targeted. And so it would seem that this is a prime area for us to do more research. Next slide. The other thing we know is that pregnancy is a window to future cardiovascular health. When you have someone go through pregnancy, there are different ways in which their cardiovascular health can be impacted. You can have someone who had underlying conditions that really didn't show themselves until the stressors of pregnancy. And because of the stressors of pregnancy, that heart disease gets exacerbated. And so then you see adverse outcomes. But there's also the other thing that we are seeing people who were healthy by everything that we can tell, they develop a pregnancy complication, and then we see a future risk of heart disease across their lifetime. And what's happening is that they're developing the heart disease on average earlier than women who did not have those pregnancy complications. And so there are a lot of questions around that. Is there something about their baseline predisposition that then resulted in the pregnancy complication? Or is it the pregnancy complication accelerated a process in their body that predisposed them to heart disease? Regardless, we know that if you have underlying heart disease and you don't know it and you go into the next pregnancy, certainly you're at higher risk of dying. Next slide. So then the next question is, well, what information are we missing? Where can research help? Next slide. I submitted these slides Friday, and so it's ironic that the first thing that I put on here in terms of what we need to know is the optimal therapeutic management of preeclampsia. If you look on social media and on the news, there is circulating a story about Shanice Wallace, a pediatrics chief resident in Indiana who just died from complications related to preeclampsia. Shanice Wallace is Black. She is a resident. And so in theory, she didn't have issues related to access to care because, as you know, with residency, you live in a hospital. She didn't have issues related to not having health insurance. You know, when, as an obstetrician, I can tell you when we have a quote unquote VIP, we break our backs to, you know, really pay close attention. But yet the healthcare system failed her. She died, you know, soon after childbirth. And so this is just a prime example of the questions that come to mind. Why did that failure happen? Is it something in how we managed her? We do still have a lot of questions when someone has preeclampsia. What is the appropriate management such that we don't increase harm from the process that's already going on? Should we deliver the preterm person immediately, or should we continue what we've been doing, which is to keep them pregnant longer if we think it's safe to do so, so that we can get a better outcome in the baby? One concern is that doing so, you know, optimizes the baby's health, but puts the mom's health at risk. And that's a newer direction for us to focus on, is that it's not just the baby here, but we have two people who we need to be healthy. Another research gap we have is how do we identify the innovative ways to take care of these women so that we can improve their access? Recent data indicated that instead of having women come in to the office for a postpartum blood pressure check, if you have them text message their blood pressures, more people participate in the process than would have shown up. And in a significant proportion of those women, they needed an alteration in their treatment. You know, either a different blood pressure medication or starting a blood pressure medication. So that new way of taking care of patients, or not so new way, because right, text messaging has been around for so long, but that we haven't adopted it into postpartum care. But the fact that that can make a difference is important. We need more studies like that to find different ways that we can make it easier for these postpartum women to care for themselves too. Next slide. There's a lot we don't know also about identifying who is at risk. When we talk about risk factors, but who are the people who are at really high risk versus the ones we need to watch in a different way? How do we allocate what resources we have? We are pushing for extension of Medicaid because we know 50% of births are covered by Medicaid, but yet this population, in a lot of states, their Medicaid ends within anywhere from 4 to 8 weeks after they've delivered. But yet we just said that the risk of death is significant within that first year after you give birth. How do we make sure that they have adequate healthcare coverage? And how do we implement that healthcare coverage in a way to optimize their health and to detect cardiovascular disease if it's there? We also know that more and more frequently, we're seeing that younger populations are developing heart disease. It's no longer just a disease of the older people. And so how do we screen these younger populations so that we can detect their heart disease and treat them appropriately before that next pregnancy or before they decompensate? But it's also identifying novel risk factors, you know, not sticking to the traditional ones that we know, but really tying the obstetric literature with what is known within the other data coming from the other institutes, such as, since I'm a sleep researcher, sleep health. We know that insufficient sleep is an area where there are huge disparities, and we know there's significant association with heart disease. we need to marry those two together and make sure that, that our women are also being screened for sleep disorders and being treated for them, because those are risk factors for heart disease. Next slide. And what about prevention, right? We always want to prevent the adverse outcomes. So preventing the heart disease among these women, you know, starting with first-time mothers. So, you know, before, you know, as far as we know, they're healthy coming into it before they've developed the adverse outcomes of pregnancy that then are then associated with future heart disease. What are the things that we can tell a first-time mom to do, or what are the interventions that can help prevent the heart disease? Once they've had a complication, there's also the question of how do we alter that trajectory? So for the mom who's had preeclampsia, who has had gestational diabetes, what can I do for her to help prevent her from developing heart disease within the next 3 to 5 years, which is how early it's been detected in actually data published by my group, that we can see it that soon in a previously healthy population. And so we need the studies that really look at the interventions. And then we need to examine what are our options for preventing across the lifespan for these populations who are high risk, taking into account subsequent pregnancies and what happens in those pregnancies. But we also need to know, is there an optimal timing of the prevention? You know, there was the NIH workshop on maternal mortality and morbidity where, you know, one researcher said that from her data, she saw that you almost have to time the intervention in, you know, the early years, you know, before the teenage years, where people get on a trajectory to heart disease. And so we don't know the optimal timing of those preventative interventions. Next slide. And I included in here the workforce because we are very much in a deficit of health professionals who are trained in cardio obstetrics. And so if we think about this, you know, it wasn't always that cardiovascular disease was the primary cause of, you know, pregnancy related deaths. When that happened, did we alter how we trained our healthcare professionals? Did we focus more on those diseases, the chronic diseases, when you're caring for these women? And I would say to you, not to the extent that we needed to. In 2020, what is being taught in terms of how to manage a pregnant woman and a postpartum woman is only slightly different from what was taught in 2000 when I was an intern in OBGYN. And so we need to catch up. And part of that is training more people in cardio obstetrics. Part of it is making sure there's a better distribution of women's cardiovascular health experts and studying how that distribution affects the population outcomes. But then also the researchers, as they're looking at these questions, need to be trained in looking at multi-level interventions for the prevention of heart disease, understanding that you're not going to have a magic pill and that people are complex and situations are complex, and that to make a difference, you truly need to intervene on multiple levels. Next slide. And so throughout on the slides, I included the SMFM infographic on health equity, because as we're looking at all of those questions, the question of equity and truly the ultimate goal, health justice, really should not be looked at in isolation, as is often done, but rather as we look at all of those research gaps that I mentioned, the question of equity should be embedded in those studies as we're trying to get those answers. They need to be integrated. And we need to include those populations who are to be studied. You know, pretty consistently, there are, you know, populations that are studied and people who are, conducting the studies who aren't necessarily experts. And so to conduct those studies, I think you need to engage those populations so that you understand their preferences and that interventions are tailored to, that they're culturally appropriate and that they're tailored, but that they are part of the question, part of the intervention. And the common mistake I see people make where they feel that someone being a member of a certain group constitutes expertise, and that's not the case. There are people who actually study the methodology and have true expertise in conducting these studies and designing these interventions. And as we do all of these studies and try to answer these questions, we need to engage those experts so that our answers are truly applicable. Next slide. I believe that's my last slide. Thank you.
Thank you so much, Dr. Lewis. Dr. Del Carmen, you're on.
Great, thank you very much. And Erica, if I could have you help me with the slides, that'd be great. So I just want to thank you all for your time and the opportunity to be here with you this afternoon to talk a little bit about healthcare disparities in cervical cancer. I want to recognize the work that Dr. Laura Rice has led, which has been key and instrumental to driving this work and this advocacy efforts forward. You can go to the next slide, Erica. So I have no conflicts. Next slide. So this is one of my favorite quotes. It was a quote from Dr. Martin Luther King in 1966 in Chicago when he gave a speech before the Medical Committee for Human Rights, saying that of all the forms of inequality, injustice in healthcare is the most shocking and inhuman. And I think that this is really a big driver of the work that we are all trying to move forward. Next slide. So we know that disparities occur across all disease sites, and gynecological cancers are no exception. When you look at cervical cancer, as I have on the slide, it is the most preventable cancer that we as gynecologic oncologists treat, primarily because there's now access to primary prevention through successful HPV vaccination, and also secondary prevention through successful pap smear screening programs. However, for a cancer that I should not see anymore, and I should not be managing any women in my practice with locally advanced or metastatic cervical cancer, we in this country continue to see disproportionate numbers of cases, with over 12,000 cases diagnosed every year and 4,000 deaths related to cervical cancer. And what I'll show you in the next slide is that these cancers tend to be shoulder, and the incidence tends to be highest amongst underserved communities. Next slide. So disparities exist because at every point of clinical entry into care, there is a relationship that has to occur between the healthcare system, the patient, and the clinician. And at each clinical event, there is the possibility or the opportunity for disparities to occur across multiple driving factors, including race and ethnicity, socioeconomic status, education, geography. It matters where patients are and where they're treated and what access they have to care. Hospital standards, we'll talk a little bit about some of those data. Variation from evidence-based treatment guidelines, biological differences where those are relevant, and then culture. So at each segment of clinical care, there is an opportunity to actually give care that is unequal and disparate depending on the situations affecting the healthcare system, the patient, and the clinician. Next slide. So when you look at the incidence and the mortality of cervical cancer by race and ethnicity in this country, you can see that in the United States, there's approximately 14 new cases of cervical cancer estimated in this year alone. There are, as I said earlier, 4,300 cancer-related deaths every year. And you can see that cervical cancer estimates, as I have shown on the histogram, are higher for certain racial groups. So when you look at the incidence and the mortality shown in red for non-Hispanic whites, the incidence is 7.1 per 100,000 women, and the mortality associated with cervical cancer in that population is 4.7%. You can see that as we move to other communities of color, for non-Hispanic Blacks, those numbers are significantly higher than for their non-Hispanic white counterparts. For Hispanics, the numbers, at least in incidence, are similar to those that we see in our Black communities. The reason that we think the mortality rate is lower for Hispanics may have to do with the fact that many of these patients actually go back to their home countries to die, so we don't capture mortality data as accurately in this community, and also the fact that many of these patients are not comfortable oftentimes disclosing their ethnicity. And so we think it's an issue in terms of also data collection. Obviously, I don't have to belabor the point, but when you look at the numbers for American Indians and Alaska Natives, you can see that there's a disproportionate burden in incidence and mortality in this population when compared to non-Hispanic whites. Next slide. So I want to spend a few minutes talking about the contributions that cervical cancer patients have made to research, and not just research in gynecological cancer, but also in biomedical research. So many of us know and are familiar with the story of Henrietta Lacks. She presented to Johns Hopkins at the age of 31 for treatment of locally advanced cervical cancer. She was treated with radiation therapy. And later, after that same year, in 1951, when she sought care at Hopkins, her biopsy specimen was actually used to do research and to develop an immortal cell line. In fact, Dr. George Gray, who at the time was doing research in this field, had spent 30 years of his life unsuccessfully trying to grow an immortal cell line. And with the biopsy specimen from Henrietta Lacks' tissue biopsy, he was able to finally establish an immortal cell line. As you can see on the slide, this contribution to research has not been trivial. These were the cell lines that were used, have been used in infectious disease research, virology, cloning, gene mapping, IVF research, and importantly used by Jonas Salk to develop the polio vaccine. Today, researchers have grown over 20 tons of these cell lines, and there are over 11,000 patents involving HeLa cells. So I think the contribution of cervical cancer patients to the biomedical research, I think, are well described in this slide. Next slide. However, we have not reciprocated that contribution, and what I'll show you now are some data around some of the gaps in research that we have documented in the medical literature around cervical cancer treatment and discovery. So this is a study that was also led by Dr. Rice, where we actually looked at racial and ethnic disparities over time in the treatment and mortality of women with all gynecological malignancies. I'll be highlighting the findings in the study relevant to cervical cancer. Next slide. So this is a large database study. So what we did is we looked at temporal trends in the treatment and survival based on race and ethnicity for ovarian cancer, endometrial cancer, cervical and vaginal cancer. We actually looked at NCB, so National Cancer Database, to address issues of treatment modalities, so whether patients were treated with surgery, chemotherapy, or radiation, and then looked at SEER data to actually be able to identify cancer-specific survival trends, looking at 17 population-based registries. For each of these disease sites, we actually looked at racial and ethnic-specific trends, looking at specifically receipt of evidence-based practice. Next slide. So as we organized the work, as it is relevant to cervical cancer, we looked at guideline-based care and adherence to those guidelines. So we looked at curative surgery or chemoradiation therapy in patients that had early stage cervical cancer, defined as either stage 1A2 all the way to stage 2A. And then for patients with locally advanced or metastatic disease, we looked at the delivery of chemoradiation therapy for those patients. Next slide. So what you can see from the histogram that I have on the slide is that on the first part of the slide under figure A, you can see that among women with stage 1A1 to 2A cervical cancer, that included a cohort of over 28,000 women. Black women were diagnosed between 2004 and 2007 were more likely than women in the other racial and ethnic groups to receive indicated surgery or chemoradiation therapy. That difference was actually meaningful with a p-value of 0.006. These findings persisted in a multivariate logistic regression model after we adjusted for age, year of diagnosis, and comorbidity index. When you look at the second part of the figure B, you can see that for women with stage 2B to 4, there was also disparities in receipt of curative chemoradiation therapy for those that had locally advanced disease, with Black women being less likely than others to receive chemoradiation therapy with curative intent. The magnitude of the disparity in that group of patients actually decreased over time. However, after we adjusted for age, year of diagnosis, comorbidity index again, we found that compared to white women, the odds of receiving chemoradiation therapy for our Black patients was 35% lower, 17% lower for Hispanics compared to whites. And when you look, if you look at the next slide, when you actually look at 5 years cancer-specific survival, you can see that that overall survival at 5 years for these patients was highest among Hispanics. Again, we think that that's attributable to either low numbers or some of these patients going back to their home countries to die. And for Asian women, however, it was lower for, the lowest was for Black women represented in the green line. And you can see that there's a big difference between mortality or survival for that group of women compared to all the other ones seem to cluster around the 80% mark. Next slide. So this is a second study done looking at, again, guideline-based care in locally advanced cervical cancer. This is also looking at data from the NCDB. These were patients with locally advanced cancer, 2004 to 2012. Over 16,000 women were included. The primary outcome, similar to our study, was to look at race and ethnicity-based adherence to NCCN guideline care. The secondary outcome was effect of that guideline-based care on overall survival. Next slide. You can see from the histogram that the rate of adherence to guideline-based care by race and ethnicity was such that 58%, it was 58.4% for patients in the non-Hispanic white cohort, 53% for non-Hispanic Blacks, and 51% for Hispanic women, again, showing a racial and ethnic difference in how often these patients were offered guideline-based care. If we can move on to the next slide, when you actually look at those data in a risk-adjusted model, predicting the probability that each patient was receiving guideline-based care based on essentially where they sought care, you can see that when we compare low-volume hospitals, there was an increase in adherence to guideline-based care in high-volume hospitals, somewhere between 48 to 63% for non-Hispanic whites, 47 to 53% for non-Hispanic Blacks, and 41 to 54% for Hispanic women. But however, what we also see is that there was a much larger gap in guideline-based care at high-volume centers, which actually addresses the issue of geography being important. And it brings up the fact that many of these patients will seek care at high-volume hospitals. So the disparities, counterintuitive, can at times be worse at high-volume centers. Next slide. This is a study that looked at research trial enrollment, and I think this is another key component to ending disparities. If we're going to move the mark forward, we need to actually be more inclusive of some of these populations that are at higher risk of developing these cancers and actually assuring that they're enrolled in clinical trials. As we move more to a personalized and targeted therapy framework in cancer, the more that we leave these populations behind, the wider the gap becomes. So this is a study that looked at 107 gynecologic oncology trials. This is the primary, I would say, framework that we have in gynecological cancers to accrue patients to clinical trials. This study included trials that started in 1994 all the way to 2013, and it allowed them to look at the experience of over 45,000 women accrued to these trials. You can see the slide speaks for itself, that accrual for Black and Hispanic patients was significantly lower than for white women in that study period. Next slide. When you look at cervical cancer trials, you can see that in the study, 65% of patients who accrued to a cervical cancer clinical trial were white, compared to only 20% of Blacks and 15% of this sort of other category of race and ethnicity. As you can imagine, this is a dire contrast to the incidence that I showed you earlier in our talk around the number of women that are affected by cervical cancer who come from the non-white communities. Next slide. So again, only 20% of patients accruing to cervical clinical trials came from the Black community. And when you look at phase 3 trials, which are the trials that really drive changes in in standard of care, you can see that only 9% of those phase 3 trials were accrued women of Black women. So again, when you think of how we make a difference and how we drive changes in the way that we practice medicine and the way that we deliver care, these numbers become even more meaningful. Next slide. The authors of this study actually did some analysis looking at expected enrollment based on how many patients you would expect that you needed to enroll in clinical trials based on the incidence of the disease in those communities and how many women were actually accrued in reality to these trials. And when you look at the cervical cancer experience, what you can see is that the observed enrollment of Black patients into GOG trials was significantly less than expected if the accrual rates were consistent with age-adjusted incidence. For cervical cancer trials specifically, there was a 4-point-fold lower enrollment of Black patients than what we would have expected to have enrolled based on the incidence of cervical cancer in that population. Next slide. Before leaving the clinical trial piece of my presentation, I want to highlight the fact that we have seen a decrease in accrual of patients and a decrease in the number of clinical trials done in gynecological cancer. You can see that there's been a decrease compared to 2011 going to 2016, and you can see also that the number of trials that were sponsored by CTEP decreased from 50 in 2010 to approximately 18 in 2016. When we actually think of what drives clinical care and changes in standard, we know that specific to cervical cancer, this framework has actually been really relevant in identifying novel therapies, including trials looking at the addition of cisplatin to radiation therapy as a chemoradiation sensitizer, resulting in an improvement in survival for these patients. Next slide. I just want to finish by saying that not dissimilar to some of the other diseases that we've highlighted this afternoon, gynecological cancers are also in the midst of this disparity story, cervical cancer being, I would say, one of the most obvious examples. And as I said earlier, as long as we continue to innovate and create more personalized targeted therapies, to the degree that we don't include communities that are at risk and vulnerable communities, we will make that gap even wider. So I think that it is the imperative to continue to look for ways to accrue into clinical trials to create a closure of that gap. Access to quality care remains a major burden for women with gynecological cancers, but it will not be sufficient to close just the quality of care unless we drive efforts around education and as well as research forward. I want to end with, next slide please, with a quote from the Constitution of the WHO. The enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being without distinction of race, religion, political belief, economic or social condition. And I think to that degree, we can all aspire to fulfill these words that were actually inscribed in the Constitution of the WHO in 1946. I want to thank you again for your time and for the opportunity to present some of the concerns that we have as gynecological cancers taking care of these patients. Thank you.
Spot on, Dr. Del Carmen, spot on. Thank you so much to our rock star panelists, Dr. Lewis, Dr. Bianchi, and Dr. Del Carmen. I want to pedal back and say thank you to Laurel Rice. I mean, seriously, Dr. Laurel Rice, amazing. This is her brainchild, her spearheading. Dr. Del Carmen was right there with her, and without them, and we wouldn't be here. So thank you, thank you, thank you. And thank you to the panelists and to the participants. I know we're running a little late, but I hope that we can at least stay on to answer one little question. I want a takeaway as a gift, parting gift, to all of our participants today about what each of our panelists think should be emphasized. Why should there be a special emphasis placed on research in women's health issues? Dr. Bianchi, do you want to start us off with that?
On mute.
You're on mute, Dr. Bianchi.
I was saying that, of course, we're a research agency, so we, research is our reason for being. Women have unique biology And, it's essential. It's 50% of the population. And not only that, women have this unique privilege of giving birth and nurturing the next generation. And I always say that our populations represent the future of the world. So it's extremely important. But I did want to comment on something that Dr. Lewis presented. She showed what we call the RCDC categories of funding on maternal health, breastfeeding, etc. Those categories did not exist until 2017. There was no way to track research funding in these areas specific to women's health until the 21st Century Cures Act required it. So, we have to speak up. We have to advocate for our populations. And I think once you see the data, you realize that there's relatively little funding. I mean, take endometriosis. It's very underfunded. It's a condition that affects 10% of women in our country. It's more than one takeaway, but thank you.
That's okay. You can add. You have a lot of insight. What I do want to say with that is that Dr. Bianchi serves in a really critical role because she and the NIH are the bridge between the scientists and Congress people, and really how we can go across and how lawmakers and federal and non-federal entities can work together to implement these steps, like in the PREGLAC plan, and just to do research. It's really important to have participants like there are in the audience across all areas of Congress, so that we can really move biology and knowledge and research forward with respect to improving the health of all women.
I just want to say one other thing. With the increase in the number of women from both parties in Congress, it has had a noticeable effect on the questions that we get asked when we go to testify at the House Appropriations Subcommittee. So, I had the privilege of testifying sort of before the increase and after the increase. And, it's so refreshing to see a member of Congress who's 8 months pregnant at these hearings, and she's asking questions that are very relevant to our mission. So I think it's a matter of perspective and having representation. And that's not only in Congress, but also in science and in the physician and healthcare community.
Yes, and Senator Duckworth from Illinois, and lactation, very, very important. So again, women are spearheading the way in Congress and in science and clinical care. And there couldn't be a more important time when we have this intersection of a pandemic on top of everything. Dr. Lewis, any passing gift, please?
I think we need to focus on the fact that women are the core of the family unit, and that with maternal health comes the downstream effects of health of the infant, health of other people within the household. With a maternal death or a maternal chronic morbidity comes with it also the psychological effects and the mental health effects. And so, remembering that as that pillar to the household, we impact everyone in that household. And so focusing on providing the scientific basis for what we do makes a huge impact across the family.
Couldn't agree more. We are the gatekeepers of health in our families across the world, across racial, ethnic, cultural, etc. boundaries. We bring people into the health system, and we also are the foundation of healthy health for our families. Dr. Del Carmen.
So I think I agree, and obviously echo everything that we've heard. I think it's an issue of justice, an issue of rights. And who doesn't want to be on the right side of justice and on delivering care that is more equitable? I think as a physician in practice, I have seen in my career the development of new drugs, new treatment regimens that have made a difference. And there's nothing more hopeful than when you walk into a room and you know that that patient's experience will be different than the patient you treated 5 years ago. who left children orphaned or a husband alone or whatnot. Because you know that it is through research and development that American medicine, I think, has written a lot of like world medicine and helped so many patients beyond this country. I just want to highlight again, I think that we talked about having more women in Congress. I think Dr. Bianchi's tenure is also something that should be recognized, because we have seen a difference in the support and her advocacy. I think has been instrumental to where we are today. And the fact that we can actually aspire to even go beyond.
Hear, hear. Thank you, Dr. Bianchi, for your leadership and advocacy. Thank you all for joining us today. Thank you to our panelists, and thank you just for everything. I hope you have a wonderful afternoon and evening. Take care, and thank you again.
Thank you. And again, thank you to Dr. Rice for spearheading this. And
absolutely.
Stay healthy. Stay
Yes.
healthy, everyone.
Yes.
Everybody stay healthy, stay safe, and obviously vote. Thank you.
Thank you.